Hello and welcome to the EuroHealth podcast, where we discuss key healthcare topics in the realms of the European Union. My name is Jiří Svoboda, and our guest today is Gabriele Fischer, Medical Director of the Addiction Clinic at the Medical University of Vienna. Professor, thank you very much for joining.
Thank you very much for having me.
So our main topic today are addictions and their connection to psychiatric disorders. Let me maybe start more personally, because your expertise combines two fields which are rarely discussed together, addictions and psychiatry. So what was for you the trigger to get into this combination of very distinct fields?
Well, I think this goes back to my education as a resident in the United States, where I was working at Washington University, which had a focus on the overlap of personality disorder, substance use disorder, and the psychiatric spectrum. And this brought me into the field. And when I returned to the University of Vienna, I just got in charge of running this unit.
What do these two fields have in common? Are there some common markers or common things that viewers and listeners can understand and link to each other very, very nicely?
Well, honestly, as a psychiatrist, as a mental health person, I need to pronounce that addiction, as we call it in a common language, and everybody understands what we mean, is actually called substance use disorder, and substance use disorder is part of the mental health spectrum. Mm-hmm. So it's not that it, on the one hand is psychiatry, on the other hand is addiction / substance use disorder. It's everything goes under mental health, under psychiatric disorders.
Mm-hmm, mm-hmm. So when it comes to the different mental health disorders, of course, substance use disorder, as you just mentioned, or SUD, is the first thing that comes to mind. But as I understood the topic, many other mental health disorders also intertwine with drug usage, such as anxiety, depressions. These are all very current topics. So how often is this developing? How often is this the case with people who use drugs?
Exactly. That's the important point, that it's almost in all cases an underlying psychiatric morbidity, what finally relates to another disorder like substance use disorder. But what's very, very important, and what's very much underestimated, that in substance use disorder / addiction is a very high genetics liability, which means if family members have been suffering on substance use disorder, it's very important to look into development of children and adolescents, how they are psychiatrically behaving, and do some assessment where it's maybe possible to avoid the onset of substance use disorder when we treat the underlying psychiatric comorbidity.
Mm-hmm, mm-hmm. So what you're saying basically is that mental health disorders, or SUD, actually can be much more likely within a family. Is that right?
Right. Exactly. It's like if you look into the other fields of somatic disorders, I think in my point of view, for the treatment, general practitioners are very important, and they usually know the families they are treating. So if there is a family with obesity, a family with heart disorders, a family with cancers, we have learned in the meantime to look into preventive medicine. And the same, of course, needs to be in the psychiatric field. And in addiction, it's very important to look into the clinical developing features early enough.
Mm-hmm. So when we have SUD and other mental health disorders, is it, for instance, possible to say what usually comes first? Is it the drug usage or the mental health disorder connected to it?
Well, I think you were really an expert asking me such questions. In a very high percentage, we do have first, we do have a genetic liability. Mm-hmm. Second, we have psychiatric underlying disorders very often, and I bring another point into the field. we have sex and gender different prevalences of psychiatric disorders. Like in substance use disorders, we very often see in boys and young adolescent males that there is a high prevalence of ADHD, attention deficit disorder, and in women or in adolescent girls, we see much more affective disorders.
So the both genders are affected similarly, but with different diseases.
Well, it is. We have a different prevalence of underlying psychiatric conditions, like more depressions on the female side, and a higher prevalence of ADHD on the male side. But still, and that's, I think it's very important, substance use disorder / addiction is still a male-dominated disorder in almost all of the substance-related spectrum. However, the women figures are increasing dramatically.
Is it also age? What's a factor here? Because you're mentioning a lot young people, young boys and young girls. Are they the most likely subjects to develop these mental health disorders connected to drug usage?
Well, it's more that first we have the psychiatric condition. And this what actually we learned over the past, would say, decades of research, that we really need to look into these clinical features of depression or ADHD. It's very easy to recognize because very often this target population is using drugs as a so-called self-medication, and then they develop a second disorder.
Okay. So, is there a scientific consensus at the connection between drug usage and the mental health disorders? Because still, it's a link which is sort of not that known. Do scientists agree with that there is this connection?
Yes, this is very well shown, and like the WHO brought about 3 years ago the classification systems, which is currently valid for all of the countries, ICD-11. And in ICD-11, substance use disorder, in addition to behavioral addiction, is part of the mental health spectrum.
So just to take maybe a step back into the history, because you started in the field in 1994, 30 years ago, was the status quo back then also like this? Was the issue understand this well, this link?
Well, I think it's we have to be honest here. We have a kind of hierarchy in the mental health spectrum. On more or less on top of the hierarchy were affective disorders, anxiety disorder, eating disorders, and if it comes down to schizophrenia, it's got much more difficult. And substance use disorder / addiction was more or less on the bottom. And the development was that it was very, very important that first social workers started to work with this target population. And over the years, it moved into psychiatry, and still, it's in some countries it's better integrated in the whole mental health spectrum. In others, it's still dislocated, which basically is a disadvantage because very often we miss to diagnose and treat the other psychiatric disorder. What is also, and ADHD is a very good example. If we treat ADHD successfully, the substance use disorder pattern is over the time not existent anymore.
Because I imagine like the substance use can serve as like a coping mechanism for dealing with the ADHD, right?
Right, exactly. They basically, and they start very early and very intensively to use drug, first with the intention of a self-medication, because ADHD refers to a disturbance in the dopamine transporter in the brain, and drugs basically release dopamine in the brain.
So You mentioned working with social workers, for instance. Let's focus on the patients for a bit. Recently, you chaired a panel at Lisbon's Addictions Conference about the role of patients in the whole process of treating treating those who have the mental health disorder and use drugs. What is the general approach to these kind of patients? Because from the very beginning, the doctor or the expert has to work with like certain quite a wide field of problems. Like on the one side, you have some mental health disorder, you have the drug addiction. How are these patients usually treated?
What makes the major difference in the whole mental health disorder spectrum that many people are stigmatized, but the highest stigma is related to drug addiction. So it's very difficult because partly the population considers that's that's dirty, and we don't want to be have any contacts. It's very often very difficult to open low threshold units in some environments because it's still a high protesting, which reminds me on the situation when HIV/AIDS came in. We had equivalent issues that people were scared that this population, they're going to be infecting others and so on and so forth, I think the high stigma in the substance use disorder field is a major, major problem. And what we really miss, like if you look I think in almost all countries and globally, we have role models. We have role models if somebody suffers on breast cancer. Celebrities go out and say, listen, go for screening, go early enough. Equivalent activities we have in other disorders. But we miss this, for example, in many psychiatric disorders. It's more popular, which is really great in depression, but we don't have this on a long-term basis in patients suffering from addiction, despite the fact, and I think this is known everywhere worldwide, that Northern America is facing an opioid epidemic for almost a decade now, and many celebrities died on it. However, there is no ongoing and on-lasting focus, and we would very much have people trying to decrease the stigma and referring to the fact that substance use disorder, addiction is a severe mental health disorder, and nobody likes to suffer on that because it's a very, very difficult disorder to deal with.
Often in this podcast, we mentioned with other guests that politicians are usually quite opposed in this harm reduction approach, right? When part of that is exactly destigmatizing the issue and decriminalizing it. What would you say it would be the key steps to enforce in order to destigmatize people with SUDs?
It is like your country is doing really great because you publicly, from my opinion, you do a lot on focusing on that. And we have a huge spectrum. And I give you one example from the non-illicit drugs. Substance use disorder related addiction is food addiction. We do have globally obesity is the 5th most common reason for high mortality. And people with binge eating disorder, they have equivalent figures like people with heroin addiction in the brain and clinically. And what we face now, and it might be also known in your country, we have a so-called fat shaming. People or young people who are already obese are marginalized, especially women. So if we set this in the scope of not only illicit drugs, there are a lot of politics is running. Like it's more or less, it's very populistic to refer, or we found in kind of a drug testing, an unannounced drug testing, we find a lot of people testing positive for cannabis. Yes, we know that about 30% of young adults smoke on a frequent basis cannabis, and cannabis is positive for 3 weeks in your toxicology. There is no causality to any behavior in regard to driving and the time they were smoking it. Of course, we don't want to have somebody driving after smoking cannabis, but the fact is, it's very often it's totally unrelated. So, on one hand side, it's there are very populistic messages, like it's very easy to refer, oh, these bad people using drugs,
Yeah.
and on the other hand, it would be much better to refer that if a successful politics would focus on preventive measures, but it's often it takes too long until you get the successful figures, and usually governments remain for always shorter over the last years in European countries.
You mentioned the interesting difference, or maybe not so much a difference actually, between licit and illicit drugs. So from an addictologist point of view, or in a psychiatric sense, is there a difference, say, if I develop an SUD from eating or SUD from some illicit drug? Is there a difference in that?
Well, the difference is, as I told you, in a scientific imaging studies from the brain, there is no difference. In the clinical features is no difference. The major difference is the criminality. As towards illicit drugs, high criminality figures are related to. And I think it would be very important to focus on the high economic costs. Substance use disorder is the fourth most expensive disorders for a society. This is related to indirect costs, like unemployment rates and also rates towards criminality issues, like being in prison. And again, if these figures would be seriously seen and discussed and related measures would be given, then appropriate treatment from the beginning on, early ages, would be really very cheap, much cheaper for the society than it's currently in the majority of the countries. But very often it's not related towards that. It's much more populistic. It's easier to say, well, we have so many drug addicts in prison. Yes, of course, because it's insufficient diagnosis and insufficient treatment.
Let's move to a slightly different topic. In one of your roles, you're also involved in the European Union Drugs Agency, or EUDA, as the member of its scientific board. EUDA recently evolved from EMCDDA, of course. What would you say is the main agenda points for your work? What are you trying to push there? What are the key topics? Is it also the decriminalization of people with SUDs?
Well, we have to understand these European Union agencies are independent agencies, and they have a great qualified staff working there. What is changing now, that significant more staff is going to be hired because the mandate got extended also to police substance use. What I think is very important, as we were talking about criminality figures before, very often alcohol use disorder is on board. And alcohol use disorder is also very much related to the high mortality in substance use disorder patients. So just to allude, we have a prevalence, like for example, heroin abuse is decreasing significantly in almost all countries. But alcohol use is in many countries, as in my country in Austria and in other European countries, still the major problem. And worldwide, we only have 8% of the patients in evidence-based treatment. And these are the figures, because we talk about a prevalence of 15% compared to a prevalence of lower than 1% in heroin dependence. So the mandate now can overlook the polysubstance use pattern which is very important. And I hope that one of the main aspects is to show that the requirement for early treatment for comorbidity, and the main aspect is to try to decrease the high mortality figures in these patients. And of course, what I would like to emphasize is also bringing the correlation to the high socioeconomic costs if you don't provide an integrated service in the mental health institutions.
Mm-hmm.
And another focus, what we should not underestimate, is the great surveillance of new psychoactive substances who appear in the European Union, and also Norway and Turkey is affiliated to AUDA as a member state. And this is the reason, for example, what we face in contrast to the opioid epidemics in the United States. We have a reporting system. We have a focal point in each country. And the country is delivering very early if the new psychoactive substances are appearing. So we hopefully can prevent any problematic misuse, for example, of opioids like we face in the United States.
Mm-hmm. You mentioned polysubstance usage. I wanted to stop at that point for a bit because maybe interesting question is that is the mental situation, mental health disorders, are they getting worse if a person uses multiple drugs at once?
Well, the multiple drug use behavior is very much related to late treatment onset, and also to a poor social situation, like a very marginalized group, the homeless people. So it is to treat psychiatric disorders, and especially substance use disorders, a multidisciplinary team should be on board. And what unfortunately we face in almost all countries in the European Union, there is a lack of psychiatrists who are the discipline to diagnose and treat these people. So we really need to work very closely with GPs, what is very important, low threshold units, and also trying to integrate patients suffering on the disorders. This is very important. It's also another hat I'm wearing. I'm a human rights expert, and the Convention on the Rights of Persons with Disabilities includes, of course, chronic mentally ill persons, and of course substance use disorder is included. And this is the option of addressing it to governments if there are deficiencies in care for these patients.
Mm-hmm, mm-hmm. So recently on this podcast we had Dr. Montenay, who is head of the Public Health Union at the EUDA, and she said that the lawmakers are moving away from the very strict approach of war on drugs and are getting more in favor of the harm reduction approach. Did you also see similar shift in your work? Are politicians getting more rational and pragmatic with the policies related to SUDs and connection with addictions?
Well, we face a pretty idiosyncratic situation. If you look in the United States, based on the UN Convention, cannabis is listed under the registered substances, and we have many states where liberalization, also for recreational use, is given. We hardly have this in European countries. There's actually a large country, Germany, what is gonna go this approach now, with a lot of procedures to try to protect adolescents. And this is again my point, the vulnerable population of psychiatric sick adolescents needs to be protected, having a easier access to drugs and having more treatment. So at the same time as we try to liberalize it, to run more harm reduction options, we need to provide a lower threshold access and an evidence-based treatment for minors and adolescents. Mm-hmm. But what we see, for example, again in alcohol, it is a scientific approach to say not no drinking, but try to learn a controlled drinking, again, adjacent in the whole mental health spectrum, to also, and we should not forget to the important aspect of psychosocial assistance, what is highly needed and wanted. I would say about 1/3 doesn't need it of the substance use dependent patient, 1/3 occasionally needs it, and the other third needs a constant assistance in psychosocial. It's not only a medical condition, it's also very important to psychosocially support them.
So recently, there was a World Mental Health Day at the 10th of October. The European Parliament held a session for this occasion, and member states and members of the European Parliament agreed that more needs to be done for mental health. But when I was listening to the discussion as well, there were a lot of discussions about the root causes of the stress from work, for instance, but not so much about the drugs were basically not discussed at all. So why is that? Why the drugs are not connected directly to the mental health space at such important institutions as the European Parliament?
Well, we have to be aware of the heterogeneous groups of European Union parliamentarians. And again, it's much more popular to refer to the high prevalence of depression and refer to the increase after COVID pandemic. And actually, what's very important, there is a very strong correlation in European Union countries. The longer schools were closed, the higher figures we see in mental health disorders and related towards the onset of substance use disorder. So politics should learn out of it, but it's still not on the. If you would ask members of the European Parliament how to what extent they would estimate is substance use disorder a problem, they would not think that it's the fifth most common disorder in the European Union and the fourth most expensive. So this is not on the radar. So, like your contribution, bringing this to the public, and a lot of more education and interaction needs to be given, and especially showing the high figures what relates to substance use disorder if we do not treat early enough and evidence-based enough.
Education and publicity is, of course, one way. Another way to spot the light on it is some more policies in this regard. What would you say needs to happen in the policy space, in the policy making, in relation to SUDs? What are the next steps, for instance, at the European level mainly?
Well, it just need to be like with the new mandate of AUDA, so much more community involvement needs to be there. So it's hopefully that this is giving the whole topic another drive. And what usually counts, and this is my experience doing this for a long time, showing people the high figures. For example, very closely related to intravenous drug abuse is hepatitis C. Hepatitis C untreated is a very expensive disorder. We have good medication to treat. There was a huge rumor at the beginning. Actually, are drug addicts reliable enough to get this expensive medication? Of course, our patients are very reliable if they are treated adequately because they are used to the daily intake of medication. If they don't take methadone or buprenorphine daily, they don't feel well. So the outcome was the treatment was very successful, and on the long-term run, it was successful for the individuals and also for the public health, because the infection rate of all the others was not given anymore if somebody was treated successfully. And these kind of figures are needed to be illustrated. The same, for example, I go again to binge eating disorder, food addiction. We have the high obesity figures, the high diabetes figures, the high blood pressure figures, the high stroke figures. If you don't deal early enough, and I finally, at the end of our conversation, I touch one aspect, in the ICD-11, in the diagnostic classification of ICD-11, which is there for globally, for each country, we have also gaming disorders. And we have a increasing number of gaming disorders in young and adolescents. And this goes in conjunction with high carbohydrate intake and continuously with early onset of cannabis abuse and also other substances. So I think we need to relate to these figures and convince and show that's a priority for politicians.
Gabriele Fischer, thank you very much for your time and contribution to the debate.
Thank you very much for having me.